Hi, I'm Dr. Sridhar Kalyanasundaram, consultant neonatologist. In this video, we will be discussing some of the common skin problems. I'll be sharing the screen and we will discuss as we go along. This is a slideshow and this is meant for parents, and obviously it will be a basic level. This is the structure of the skin, and as you can see, we have the topmost layer, the epidermis, and the top of the epidermis is called the stratum corneum, which has a protective function. Below the epidermis, we have the dermis, and this has the supporting structures. And below the dermis is a subdermis, which carries the blood vessels, and it also has the fatty layer. The thickness of the skin and the texture depends on the part of the body. So if it is over the face, it's very thin skin and it's more vascular, while if it is over the soles and palms, it's very thick skin. This shows how thin the skin is in the fetal skin, and the newborn skin, it's relatively having more layers and thicker epidermis, but compared to the term skin, it's still a thin one. So newborn babies, whether term or preterm, have very sensitive skin, and we should be very careful to manage them well. This image shows us a fetus, a baby who has just been born, and the face is covered with this white caseous material. It's called vernix caseosa. It's a natural substance. The fetal shed cells in the womb, as well as the sebaceous secretions. Some components from the urine may sediment on the skin as well, that the baby pees in the mother's womb. And all these components form the vernix. If the baby has pustule in the womb, it appears green, and that's the meconium's related condition. The vernix has a protective function to the fetal skin because the fetus is in the womb and covered by liquor all the time. After birth, it has a protective function in the form of moisturizing the skin and also some infection protective factors. We don't try to wipe the vernix off immediately. Leave it for 12 to 24 hours, and baby settles in nicely to the postnatal life. This image is cephal hematoma. Compared to the caput, which is just a fluid retained in the back of the head due to the descending position. The cephal hematoma is actually a blood collection. It happens in vaginal deliveries. It can happen even without significant trauma, because during the path, descent down the path, there is a negative F suction effect, and this may lead to small bleeds in the skull bone surface. So this bleed is actually between the layer of the skull, and the skull bone has a top lining called the periosteum, and between the two layers of the periosteum, this bleed happens. So subperiosteal bleed. It doesn't cause any problems because it's usually restricted by the tight periosteum once it stretches to a certain degree. So it doesn't become a massive bleed usually. The blood breaks down and leads to the jaundice producing pigment, and that is one of the risks associated with the larger cephal hematoma. Avoid vigorous massage, but you can handle the baby normally. It doesn't hurt the baby. So be aware that it takes a few weeks to resolve. It becomes solidified and the blood absorbs with time. The image here shows us the normal rash that we get in babies called erythema neonatorum, or erythematous rash of the newborn. So it's a reddish rash, and you get white papules in the middle. Sometimes you get small pustules as well. And we have no problems arising from this rash. Parents may be concerned, but it is usually no problem. This rash is acne, and it typically happens around 3 weeks to 4 weeks of age, and it stays till 2 to 3 months. It comes and goes during this phase. Many babies have a milder form of this, and some babies have significant pustules, and actual whiteheads or blackheads may be seen in some babies. This is related to the sebaceous secretions as well as the maternal hormones, and it's benign. It doesn't need any treatment, but avoid oil applications, avoid excessively hot environments. Sometimes it joins with prickly heat, and they may present together because both have an origin in a hot environment. We also have to moisturize the skin. So use a moisturizer, but don't use oils. The normal umbilical cord, typically you have the cord clamp and it dries and separates from this area. Avoid covering this with the nappy. When you fold the nappy below it, you should make sure that the plastic surface is outside, because the absorbable part of the nappy should be till the top. Otherwise, there will be leak of urine and the baby may be uncomfortable as well. This image shows us how it separates with time, and it dries and shrivels. The normal bacteria that colonize the skin have a role in its separation. Then it shrinks and falls off at this edge. When it actually falls, it may still be moist inside and it appears yellowish or pinkish. It's normal. It dries on its own. During the sticky phase of its separation, you can use alcohol swab to clean it, but otherwise you don't need either alcohol or powders to treat it, because antibiotic powders may delay the separation. Talcum powder has to be avoided in babies because there is a risk of inhalation, and you must have heard about inhalation of powders in the press as well. So one of the problems we see is umbilical sepsis. Umbilical granuloma is where a small pink area remains and it usually absorbs on its own. It doesn't need any treatment, but in the large ones we may need cautery. However, in this baby, we can see that there is a suspicion of infection because there's significant redness around the belly button area. And you may also see pus discharge if this is lifted. So this is umbilical sepsis, and this baby needs to be admitted for intravenous treatment after doing blood culture and blood tests, because this is a serious condition. The blood vessels running from the umbilical vein go through the fetal liver, and in the newborn period as well. When it shrinks, this infection can actually go through, and it can cause problems in the future related to the liver. So we do have to be careful with the monitoring the umbilicus. This is a mild nappy rash, and obviously we can make sure that we are not eroding the skin, leave it open for some time, use a good barrier cream both for preventive use and treatment, and it tends to heal within a few days. Mild lesions like this may need a small topical antibiotic application, but you don't need steroids to treat it. This rash is typical fungal nappy rash, and fungal nappy rash is not uncommon because of fungus is present in the mouth sometimes normally, and sometimes from the breast of the mother or from the bottle, and it goes down in the stools. When the skin is broken, the fungus can get into the skin and you get the candidal or fungal nappy rash. So this needs antifungal treatment. We should be careful with the use of steroid containing preparations. Don't overuse steroid containing preparations. A mild steroid may help to heal it fast, but continuous use causes damage and it can thin the skin. So you should not be considering a steroid cream as a regular nappy cream, only under physician advice and for a limited period of time. This is strawberry hemangioma. It's not uncommon, and it's seen usually as a pinkish dot or a small spot at birth. It grows over the first few weeks. It's typically more common in premature babies who may have more than one, and term babies also they may have. When it grows big like this, there is a risk of ulceration from the surface, and that's a main complication. If it is located in areas like the eye, near the eyes or over the tip of the nose and things, we may need to treat it. Or if it's in the nappy area where it may break down and ulcerate, we may have to treat it with medications called propranolol. Previously, we used to give intralesional steroids or laser, but nowadays with propranolol, it tends to resolve well. It does need to be treated for a prolonged period to resolve, and it's usually under monitoring. And these kind of lesions on the limbs usually resolve by 1 to 2 years on their own, and provided we watch them carefully without breaking down. This is oral thrush. Thrush is a fungal infection which affects the oral cavity in babies, and sometimes older children on inhaled steroids may develop thrush as well. So we have to ask them to gargle their mouth after they use inhaled steroids if they're using it for asthma. And oral thrush in babies typically happens if the mother has rash on the breast, which can be a fungal rash. It can also happen if you're not sterilizing the bottle carefully and the yeast gets into the mouth. It appears thick coating on the tongue, unlike the normal milk coating, which is thin, and this doesn't come off easily if you try to wipe it off. You also typically have lesions over the palate, the uvula, which is the back of the mouth, and the lips. So these lesions confirm that it's a fungal infection. It usually needs treatment with the oral antifungal gel, which will be prescribed by your doctor. And it needs to be treated for 7 to 10 days. If it keeps recurring, you need to remember to treat the mother's breast or make sure the bottle is sterilized. And if it is persisting for a prolonged period of time, we may need oral antifungals, and if still resistant, we have to think of immune deficiency conditions. Cradle cap again is seborrheic Seborrhea capitis, and it's just the seborrhea, the sebum secretions which crust on the scalp. Dryness predisposes to this as well, and so we have to have a regular system of washing the scalp with a mild shampoo, applying oil, and combing the scalp so this doesn't accumulate. And once it accumulates, you may need some keratolytic gentle washes. We have preparations meant for that. If there is inflammation, we may need a mild steroid application under supervision. Just like atopic dermatitis, sometimes infection may get into this area as well, and we have to treat it appropriately. This is just simple dry skin, and you need to have a regular moisturizing routine. Moisturizers need to be applied on wet skin to be effective. This baby has mild inflammation on the cheeks, which is a start of the atopic dermatitis. Typically in early infancy, many babies have it if you don't moisturize the skin well, and we have to look after the skin right from the beginning. Avoid soaps, use soap-free cleansers if you can, and use moisturizers on wet skin on a regular basis. If you see redness coming up, you need to moisturize more intensely. And then if it still worsens, you consult your pediatrician because this may need a mild steroid cream. In the more advanced stages, it's a chapped appearance and there may be infection with crusting. So we need more specific treatment and discuss with your pediatrician or the dermatologist. And this is a very severe eczema where because of the scratching, you have significant lesions, scratch marks, and its child is miserable. So they don't thrive well because they are not they don't feel like eating well, and you do have loose protein from the shedding scales on the skin as well. So we should treat it aggressively. You may need a wet trap, you may need regular medications under dermatologist supervision. And as the child gets older, it becomes a flexural lesion, and regular applications may need to be used if it is persisting. So we should teach the child not to scratch, dabbing on the skin, using moisturizer regularly, and tapping instead of rubbing or scratching may help. This just illustrates that we have a normal skin barrier and the allergens cannot enter the skin. However, in atopic dermatitis, the skin barrier is weak and the allergens can enter the skin, so you have a higher chance of getting sensitized. So we advise not to use food substances on the skin as topical applications. Some cultures use gram flour and even egg yolk and things. Please don't use that on the skin as you may increase the risk of allergy. So I hope this presentation was useful, and if you have any questions, don't forget to leave a message for us. Thank you.